We're going to talk about Chapter 22, Non-Malignant Lymphocyte Disorders. So here we're going to begin discussing conditions associated with quantitative and qualitative alterations in lymphocyte and describe some of the disease states and other types of acquired characteristics seen in lymphocytosis, and a discussion of lymphocytopenia that involves immune deficiency states, both acquired and congenital, will follow. The emphasis is on the lab features that allow the disease to be diagnosed and differentiated from any types of neoplastic precancerous states. So we're going to see evidence of disease when we find abnormal concentrations of lymphocytes and or reactive lymphocytes in the peripheral smear. Now we'll talk about some terminology first. An increase in lymphocyte is called lymphocytosis. It can result from a relative or absolute increase in the lymphocytes. An absolute lymphocytosis occurs in adults when the lymphocyte count exceeds 4.8 times 10 to the 9 per liter. And a relative lymphocytosis is present when the lymphocyte differential exceeds 45%, depending on the race. Now, lymphocyte counts we know are usually different and higher in children. Therefore, an increase or lymphocytosis from the ages 6 months to 4 years is greater than 8.5 times 10 to the 9 per liter and greater than 65 as a relative value. Lymphocytosis is usually a self-limiting reactive process that occurs in an infection or some type of inflammation. So once lymphocytes have been stimulated by an infection or inflammation, they enter into various stages of activation, resulting in a morphologically heterogeneous population of cells that you can see on the peripheral smear. So when we talk about reactive lymphs or atypical lymphs, they're usually large cells with irregular shapes. They have the cytoplasmic basophilia, which is quite dark. Occasionally, you might see some vacuoles or granules, and the nuclear chromatin is more dispersed, and the nucleus looks stretched. Now here we have a couple images of relatively small lymphocytes. Okay, you can see the picture on the left-hand side here. Okay, the nucleus is the size of these red cells that are next to it in the picture. Now similarly, this is a little bit blown up, the picture on the right, where we have the nucleus of the lymphocyte being similar in size to the red blood cell with scant blue cytoplasm. And here's a little bit darker, but again you can see the different staining patterns of the right stain here. Now let's talk about a reactive lymphocyte. Okay, so this is scalloping around the edges of red blood cells. The nucleus is stretched quite a bit, the chromatin dispersed. Now you can see the deep basophilia around the red cells. Now this is a typical reactive lymphocyte that many textbooks show. Okay, now on the right here, this is a monocyte, has multi-vacuoles, a convoluted nucleus, and then a bluish-gray cytoplasm with looking like ground glass appearance. Now here is just a couple larger lymphocytes. Okay, these are large granular lymphs. They have a few granules in the cytoplasm here, but again we have a large nucleus, okay, condensed here, right, circular, and we still have the bluish cytoplasm here. Okay, yes, this nucleus is a bit bigger, but we still have lymphocytes in this type of stage as well. Now here we have an image of an immunoblast. So as the lymphocytes are activated due to some kind of antigen, they go through immunoblast transformation, where they look very dark, very condensed. Okay, so you have an immunoblast here, an immunoblast here, okay? And they are very basophilic, okay? The nucleus is still very large, the cells are large themselves, okay? Then at 3 o'clock here, you have a reactive lymph. Now, you would see this better if it wasn't squished on top of two cells, but you see some basophilia around the edges, and this is going to look like a stretched nucleus. The first condition we're going to talk about that involves lymphocytosis is infectious mononucleosis. This is a self-limiting lymphoproliferative disorder caused by the Epstein-Barr virus. It usually affects younger adults and peaks the age of infection from 14 to 24 years. It's usually transmitted through direct contact with saliva, and definitely immunocompromised individuals are at increased risk. Now, once infected, 80 to 90% of adults have had exposure, therefore they have lifelong immunity. Epstein-Barr virus will attach to the B cell CD21 receptor, and once they bind, it activates the expression of the B lymphocyte growth factor. So once internalized, the virus is incorporated into the B lymphocyte genome, instructing the host cell to begin production of Epstein-Barr virus proteins. Now, the classical symptoms that you will find, or the triad, is fever, pharyngitis, okay, so you're going to have a very sore throat and redness. Look how these lymph nodes and tonsils become reddened and swollen. And you're going to have lymphadenopathy, okay, so swollen lymph nodes, okay? You will also feel very fatigued and tired. Usually with children under 10, they will be asymptomatic with reactive lymphocytes and have an increased C-reactive proteins. Now, anyone over the age of 10 may have liver enzyme involvement too, and an enlarged spleen and liver. Now, in the hematological findings for the lab, you're going to need serological tests to confirm the diagnosis. But in the peripheral blood, during active viral infection, an intense proliferation of lymphocytes occur. So this is where the lymphocyte count can go from 12 to 25, primarily because of the absolute lymphocytosis. So it usually lasts 2 to 8 weeks, and lymphocytes are over 50% and greater than 20% of them are reactive, and they're this form of reactive types of lymphs in infectious mono. Okay? Platelets can generally be decreased, and it has similar morphology to other viral diseases, but it has to be carefully differentiated from other types of cells. Okay? So one of the serological tests that are used to differentiate this disease from similar diseases is providing the heterophile antibody test, or the monospot test. Here, the blood of patients with infectious mono have greatly increased concentrations of this transient heterophile antibody that will agglutinate sheep or horse red cells that are not specific to E. Epstein-Barr virus. So antibodies specific for Epstein-Barr can be identified by absorbing the nonspecific antibodies from the patient's serum with guinea pig antigen, then testing the absorbed serum with horse erythrocytes. The infectious mono IgM antibodies will react with the horse erythrocyte, and positive agglutination will be seen. Next, we have a condition Toxoplasmosis, which is a result of an infection of an intracellular protozoa, Toxoplasma gondii. This intracellular parasite can multiply in all body cells except erythrocytes. Infections are usually asymptomatic but pose a significant threat to the fetus of a pregnant woman. Toxoplasma gondii is acquired by ingestion of oocytes from cat feces or from inadequately cooked meat. So you really have to distinguish this morphologically from infectious mono. So here you will have a negative heterophile antibody test, and you will have specific serological test for Toxoplasma gondii for diagnosis. Now here the reactive lymphs are increased and present, but they are quite dark in their basophilia and can and needs to be distinguished from lymphoblasts or cancer cells. Now here are the oocytes that are ingested and seen in the tissue of a patient positive with toxoplasmosis. Cytomegalovirus is the next condition that causes lymphocytosis, and it's an infection caused by the herpes group cytomegaloviruses that can be either congenital or acquired. Infection can occur in neonates when the virus from an infected pregnant woman crosses a placenta and infects the fetus. Acquired infections is spread by close contact, blood transfusions, and sexual contact. And here we have a leukocytosis with an absolute lymphocytosis. You see reactive lymphocytes. Also, then you have a negative heterophile antibody test. Now you have to do molecular DNA or specific serological testing for diagnosis of CMV. So it's the most common viral infection that complicates tissue transplants and can cause a significant cause of mortality in immunocompromised patients. Now here the lab findings include an absolute lymphocytosis, but as you see, many of the lymphocytes show a reactive morphology here, okay? And some of the lymphocytes can even have a little cleave in its nucleus. Now, reactive lymphocytosis, previously called infectious lymphocytosis, is a reactive immune response associated with several common viruses that affect children. The most common type is adenovirus or coxsackie virus types of infections. Leukocytosis and lymphocytosis occur in the first week of illness and subsequently return to normal. The lymphocytes are rather small here and appear normal rather than reactive. But you can see on the skin that you can have definitely pustules and outbreaks due to this reactivity virus. And here, normally, the lymphocytes will look normal, okay, and not as reactive as infectious mono or toxoplasmosis. The next condition is Bordetella Pertussis, or whooping cough. Is an infectious with Bordetella Pertussis that causes a blood picture that's very similar to that of reactive lymphocytosis. The leukocyte count overall typically doesn't rise above 20 to 25 times 10 to the 9 per liter, but on occasion can reach 50 times 10 to the 9 per liter. So the rise here is caused by an absolute lymphocytosis of BT and natural killer lymphocytes, along with increases in neutrophils and monocytes. Now here the granulocyte can show toxic changes, but the lymphocytes are very small and have a condensed chromatin and indistinct nuclei. So lab diagnosis includes culture serology, immunophenotyping, and PCR. Now, culture is a gold standard and is specific but not sensitive. Here we see many of these small lymphocytes. Look how condensed, you barely see any cytoplasm there. Okay, so this is lymphoproliferation from whooping cough. Okay. Okay, another condition associated with lymphocytosis is a condition called plasmocytosis. So, from this image, you can see that by this pointer here, that this is a plasmacytoid lymphocyte. Okay, it has an eccentric nucleus, it's got very deep cytoplasm, and these are usually associated with infectious states. So normally, plasma cells are not found in the peripheral blood and constitute less than 4% of the cells in our bone marrow. So most of plasma cells are found in the medullary cores of our lymph nodes, okay, and they can occasionally be found in the peripheral blood when intense stimulation of the immune system occurs, such as when we experience bacterial infections, such as rubella, and then some viral infections such as infectious mono or toxoplasmosis, tuberculosis, and syphilis. Now it's time to talk about the conditions that decrease our lymphocyte count. And overall, the terminology is called lymphocytopenia. So this occurs when we have an absolute lymphocyte count that's less than 1 times 10 to the 9 per liter in adults and less than 2 times 10 to the 9 per liter in children. Here, this is very dangerous because we have an impaired ability to mount an immune response. Just as we saw in lymphocytes with neutrophils, with decreases in neutrophils, it's also caused by either an increased destruction method or a decreased production method. Now, corticosteroid therapy can also do this because it causes a sharp drop in any circulating lymphs within 4 hours. So the decrease is caused by the sequestration of lymphocytes in the bone marrow, but usually these values will return to normal after a day. Acute inflammatory conditions, including viral, bacterial, and other transient lymphocytopenia, can occur. Malnutrition is the most common cause of lymphocytopenia. That's not a disease process, and starvation can cause thymic depletion of all of those T lymphocytes. Now, both congenital and acquired types of disorders can be seen with immune deficiency types of lymphocytopenia. Now, when we talk about immune deficiency disorders, they're characterized by impaired functions of one or more of the components of the immune system, so T, B, or natural killer lymphocytes. In some disorders, the number of these are also reduced. So the first condition here is acquired immune deficiency syndromes, or AIDS, highly lethal immune deficiency disease, first described in 1981. So the disease is caused by an infection with a retrovirus, human immunodeficiency virus, either type 1 or 2. Here, patients experience weight loss, fever, swollen lymph nodes, thrush, rash, and intermittent diarrhea. Usually discovered with repeated infections with multiple opportunistic organisms here, and the transmission is usually through sexual intercourse or contact with blood and blood products. Now there are 2 types here. HIV is most common worldwide and is more pathogenic. So mother-to-child transmission is relatively common here. Now in HIV, classification 2 or strain 2 is found in West Africa, Mozambique and Angola more commonly, and is less pathogenic, and the duration of the infection is definitely shorter, and here the mother-to-child transmission is relatively rare. Now, not all persons infected with HIV will have AIDS. The CDC developed case definitions of AIDS for surveillance reasons that have been allowing for the staging of HIV based on immunophenotyping of CD4 lymphocytes in their clinical conditions. So, the etiological agent for HIV-1 infects the helper T lymphocytes via the CD4 receptor. They selectively deplete this lymphocyte subset, and you can also affect the monocytes and macrocytes also, but they're not destroyed. Now here it defects in cell-mediated or humoral immunity, severely depleting your helper cells. So usually you'll have an inverted CD4 to 8 ratio, where the normal is 2 to 1 for CD4 to 8. So you really have to monitor the viral load against the HIV RNA copies. Now lab findings, you'll have multiple hematological abnormalities. Here you'll have leukopenia, lymphocytopenia, and this could show some reactive forms if there are any present, and you may have neutropenia. You'll have a mild or moderate anemia with the MCV of your cells greater than 110 after receiving some drugs for preventing AIDS. You'll have thrombocytopenia, you might have low iron as well. So here you can see that you have some rashes that are usually over the skin, and that's a chronic rash, and you could tell that these lymphocytes have been affected as they're coming out onto the skin. Now let's talk about congenital immune deficiency disorders, which are characterized by decreased lymphocytes and impairment in either the T-mediated immunity, T lymphocytes, humoral immunity, or the B lymphocytes, or both. Now here, lymphocytes usually appear normal. They have a functional immune impairment, so they often apparent from birth or very young when children have repeated types of infections. So the first type we're going to talk about is the severe combined immunodeficiency syndromes. So this includes a heterogeneous group of disorders resulting in major qualitative immune defects involving both humoral and cellular immune functions. So these disorders include numerous and diverse genetic mutations with different types of inheritance patterns, mostly sex-linked or autosomal recessive traits. Both T and B lymphocyte lineages are functionally deficient. The lymph node examination reveals a lack of plasma cells, B lymphs, or T lymphs. No lymphoid cells are found in the spleen, tonsils, or intestinal tract. The bone marrow is also deficient in plasma cells and lymphocyte precursors. So you will see frequent recurrent infections, skin rashes, diarrhea, failure to thrive are the characteristics finding for SCID. Death related to overwhelming sepsis usually occurs within the first 2 years of life if it's untreated. So bone marrow transplantation, IG therapy, and gene therapy are the only options for a successful treatment. Okay, so let's talk about Wiskott-Aldrich syndrome. With this syndrome, I like to use the WAX-TIE acronym, as WAX-TIE meaning Wiskott-Aldrich, X for X-linked recessive disorder, and classified by a triad of physical conditions. So TIE, so thrombocytopenia, decreased platelet count, immunodeficiency resulting in recurrent infections, and eczema, you can see all over this patient's skin here. So wax type. Now because there's an extreme thrombocytopenia, a lot of children die before the age of 10 as a result of infection or bleeding. So therapy here includes treatment for bleeding and infection. DeGeorge syndrome is a congenital immunodeficiency marked by the absence or hypoplasia of the thalamus. Here you will also see some heart defects or dysmorphic facies. Hypocalcemia is also a feature, and patients can exhibit seizures due to a low calcium level. You're also going to have a decrease in blood T lymphocytes and decreased cellularity of the thymic-dependent regions of the lymphoid tissue because of a lack of a thymus. Here you have normal B lymphocytes and IG levels, but you have an increased susceptibility to viral, fungal, and bacterial infections, and death can occur in the first year of life unless thymic grafts are performed. The next is sex-linked A-gamma globulinemia, or Bretton's disease. Here, patients exhibit frequent respiratory and skin infections, usually with extracellular catalase-negative pyogenic bacteria. You have a loss of function mutation of a tyrosine kinase seen in 90% of these patients, where it blocks the B lymphocyte maturation in the lymph nodes, so you see a decrease in B lymphocytes and an absence of plasma cells. T lymphocytes here are normal in this condition. Now, because it is X-linked, female carriers of the disease have normal immunity, and all of their B lymphs carry the paternal normal X chromosome, suggesting that the normal X chromosome confers a survival advantage. Okay. Ataxia telangiectasia is a progressive neurological disease and an immune dysfunction that has a predisposition to malignancy. Individuals are ataxic and develop vascular lesions, as you can see in the eye here. There are many, okay? And it's characterized by progressive neurological disease. The defect is in cell-mediated immunity, where you have dysplasia or hypoplasia of the thymus here, and you see depletion of T lymphocyte areas in the lymph nodes, but the B lymphocytes seem to function normally. The last one here is hyper-IgE syndrome. It's identified by advanced molecular techniques, and its mutations are linked to immune deficiencies that result in decreased cell signaling, decreased lymphocyte counts, and decreased immunoglobulins, except for an increase in the IgGs. Patients have recurrent infections, and they're extremely susceptible to opportunistic infections.